Good afternoon, everyone. Thank you so much for this opportunity to present my study titled Survey of Orbital Tumors in Elderly Population. It's a large case series, and I'm thankful to my mentors for their constant guidance. Um, so orbital tumors, orbit, as we know, it has a wide range of structures present there, and which can be site of origin, any of these structures. Based on the origin, we can have either a primary tumor, secondary tumor, or metastatic tumor. Based on the nature, it can be benign or malignant. Based on morphology, it can be well encapsulated or diffuse. So when we have to diagnose orbital tumors, surgical biopsy is the gold standard. It can be either incision or excision, but there are other modalities of treatment also. This is a classification proposed by the Shields group, which is a very systematic classification according to the structures present and what tumors can arise from that. And we have used this classification to categorize the tumors in our study. So when we look at the review of literature and the prevalence of space-occupying orbital lesions, there is a large variability that exists in the surveys. Why? Because it depends on where the data is coming from. Is it coming from a clinical ophthalmological clinic or an ENT-associated ophthalmology clinic or a surgical orbital biopsies? The age can also vary it, and the geographical location. And of course, limited information is available about the spectrum of orbital space-occupying lesions in senior adult populations in India. We know it is a diagnostic dilemma. We know it is a challenging situation. So we need to have a correct and timely diagnosis to avoid unnecessary investigation that we make the patients go through, and also the unnecessary procedures and treatment. So we have to have a good knowledge of the spectrum that exists. So with this aim, we wanted to analyze the spectrum and the management outcomes of these orbital lesions in elderly population, specifically in the age group of 60 and above. So it was a retrospective consecutive interventional clinico-pathological series, and we had a total of 223 cases. All of them underwent a thorough clinical examination, a radiology, either with a CT or an MRI, and surgical histopathological proven tumors were taken in the study, and sample was sent for histopathology, and management and outcomes was studied. And the same surgeon did the surgery, and pathologist was also same, and diagnosis was made in all the cases. So we had a median age of 65, and I've shown the age range here. Mostly fell under 60 to 70 age group, and males slightly predominated more than the females. Bilaterality was seen in 9% of the cases. Most common presenting symptom, clinical feature I would say, was mass and protrusion, followed by protrusion and diminution of vision. And when we took the history, 3.1% already had a systemic malignancy. Tumor characteristics, we have studied it in detail, but most common was a firm mass, which was diffuse, heterogeneous, and present from anterior to mid-orbit. And histopathology for the diagnosis, the approach was, of course, according to the position of the tumor. The primary treatment was maximum incision biopsy in most of the cases, followed by excision. Interesting thing to note was exenteration was more common probably 10 years back, and it kind of like decreased as the data went along, because it is a 20-year-old study, a 20-year study period. And this is the data that we found. Most common lesions were lymphoproliferative. I have just noted down the most common ones from each category, and I'll be showing it in a separate table. But I would say this is the most important slide from my presentation, and the take-home message that 65% of the lesions in this set of population were malignant lesions, and only 35% were benign. This is the top 3 benign and the malignant lesions that we found in our survey. Additional treatment had to be given according to the pathology of the tumor, and median follow-up was of 4 years. Another important thing to note was metastasis that we found as we followed up the patient. 9.5% had a systemic metastasis in the follow-up period. So that is also important to remember, because these need continuous follow-up throughout lifetime. Final outcome was unknown because of loss to follow-up, but most of the cases were alive and did well. So this is my survey and the table that I made according to the tumor types and in detail the survey that we found. So I would say there is increase in the longevity as is seen in the country, and this set of population is increasing. Another challenging thing in this set of population is they have a resistance to seek healthcare, and they need less downtime, and tolerance to treatment is also less. So we need to be accurate in our diagnosis. This is just a case to show that we thought that it is a lacrimal gland tumor, which proved to be so, but a systemic evaluation was required, and it was a rare kind of a lacrimal duct carcinoma. These are the other surveys that exist, and another one from the senior author, and our findings were corroborative with this study, malignancy being predominant and lymphoma being predominant malignancy that was seen. So I would just like to conclude by saying that it is imperative to know the pattern of frequency of distribution of these tumors to make the correct diagnosis, and it just highlights the different pathologies that can exist, and it is prudent to keep malignancy in mind when we are dealing with this set of population. Thank you so much. These are my references. Thank you so much.
Nice presentation. I just had a question. You've had this data collected over 20 years,
Yes,
and especially with lymphomas, I'm curious whether the rate of lymphoma has changed over the years.
So the
Have you
most
looked at that?
So lymphoproliferative predominated, and the most common always throughout that study was ENMZL, followed by follicular, as is like
So
known
the
in the
question
literature.
was actually the rate. Has that changed? So have you been seeing more tumors in the recent years compared to, let's say, the first 10 years? Was there any difference in the rate
only
of tumors per
specifically
year?
to lymphoma.
Yeah, the lymphomas or any of the other tumors. As you know, the rate of lymphoma worldwide globally is increasing. And so I'm wondering if you found the same thing in your study.
So I have not compared it with the old data, but probably I can look into it, like how with the IHC and everything it has changed over the years.
So exactly on that point, if you could create a split of the first 10 years versus the next 10 years,
Correct, yeah.
and look at the change of proportion, that will tell you, couple of things. One is mean age at diagnosis in terms of malignant lesions, and the proportion of whether, say, lymphoma has increased or not. The other question I had was, Richard Allen in one of his talks on orbital Mets says that he has a very low threshold for suspecting malignancies, and says a patient above 60 with an orbital mass is near almost always a malignancy. Did you have any proportion, any kind sort of a similar kind of observation where beyond a particular age, the proportion of malignant tumors was greater than that of benign tumors, or any sort of age-wise description in age-wise split or comparison?
I did not, in the age range I have not done, but we have a similar concurrent study that is done by another fellow, which sees the pediatric population. So that definitely proves that their benign tumors predominated, and in my series 60 above, malignant tumors predominated, like with the majority of the ratio.